We can start.
Sure.
Dr. Jitu, we can start.
Yes. Okay. Good evening, everyone. A warm welcome to the ISA National PG online class. This is Dr. Jitu Mohan, Senior Resident from the Department of Anesthesiology and Critical Care, MES Academy of Medical Sciences, Kerala. And I'll be one of the co-hosts, screen coordinator for today's class. And in today's session, the topic for discussion will be arterial blood gas analysis. And as all of us know, this topic is of fundamental importance for as far as an anesthesiologist is concerned. And today's academic session is aimed to ensure that all the attendees are well equipped for a systematic analysis and interpretation of arterial blood gas analysis in day-to-day practice. And before we commence with the academic session, let us see the blessing of Ma Saraswati with the Saraswati Vandana. May I now request Dr. Sukhminder Bajwa sir, Honorary Secretary, ISA National, to please address the audience.
Thank you, Dr. Jitu. I think this class is for everyone, not just PGs. I think a refreshing course for the teachers also, as well as the practitioners also. Invariably, majority of us in the field of anesthesiology are working in the intensive care units, and it's our day-to-day bread and butter, the ABGs. But there are many myths, there are many fallacies, there are many sometimes difficulties reading of the ABGs. So I think none other than Dr. Subodh, who is well versed with this technique. I know I'm waiting for his Ulta Approach. That is, I think, going to be something unique and new for me also. I will be looking forward to this class because Dr. Subodh is one of the very good teacher in the present day scenario in our academics. So I hand over back to Dr. Jitu. You start the class.
Thank you, sir, for your valuable insights ahead of the class. Now, I request Dr. Sarina George, our co-screen coordinator, to introduce our esteemed faculty for today's session and outline the session formats and rules. Over to you, Dr. Sarina.
Thank you, Dr. Jitu. Good evening, everyone. I am Dr. Jitu's co-screen coordinator, Dr. Sarina Mary George. I am currently working as a junior consultant in St. Stephen's Hospital, Delhi. And it is my immense pleasure to welcome our eminent speaker for today, Dr. Subodh Chaturvedi. He is a consultant in anesthesiology from Indore. He has practiced cardiac anesthesia for 10 years and bariatric anesthesia for 6 years. He runs an online educational platform called Clinical Guruji for doctors, and this has more than 8 lakh subscribers on YouTube. He has expertise in artificial intelligence, simulation in medicine. He has many achievements, he has created the website for ISA national, state, and city branches. He has developed softwares for data management for IRCF. He has also won many prizes like the ISA President Special Award for creating ISA National website and ISA Public Awareness Award. Sir has a very special interest in educating the young anesthetists, and which is according to the need of the hour. And he is a great educator and an inspiration to all the budding anesthetists, and a wonderful teacher. We welcome you again, sir, to this for our ISA program. Before we begin, I would like to remind all of you about the rules that we will follow during this session. First of all participants will be muted during the entire session. If you all have any questions, please put it in the chat box and we will try and answer them once the session is over. And lastly, please keep all of you, can you please keep your videos off. Thank you everyone for your cooperation. And now I hand over the stage to Dr. Subodh so that we can have an enlightening session. Thank you.
Good evening and thank you so much. Thank you so much to Sukhminder sir, ISA National, and all the people who invited me here. I'm Dr. Subodh Chaturvedi. I practice anesthesia. I practiced cardiac anesthesia and bariatric anesthesia. So ABG is like one of my favorite things to teach. Yesterday only we were discussing about how to run this class, and Sukhminder sir said ki let's ask a few questions to PGs also in the due course of the lecture, and let's give some exciting prizes to the PGs. So I redesigned this class as a PG quiz rather than a class. Don't worry, I'll keep teaching, but all the while I'll keep asking you some questions, very easy questions, very stupid questions, and all you have to do is to jump to your chat box and write the answer. One more thing, it is an interactive class, so I would expect, like right now I see at least 150 people logged in. So I would expect at least 50-60 answers to every question. So please do write. Otherwise, if it is not interactive, then there is no point in teaching. I can finish this topic in like 25 minutes and you won't get anything. But if you keep interacting, I'll teach this for like 1 hour or 1.5 hour, and you will learn a lot from this lecture. So first of all, let's start with the disclaimer or the rules of the game as such. First of all, just believe, even if you are practicing anesthesia, you are a PG, you are a third year, nobody knows you, nobody is judging you. Please interact, because unless you answer it wrong, you will never know the right answer. So please participate in the chat box. Secondly, it is already going to be a long class and I will not touch alkalosis. Thirdly, I can converse in English, fair enough, but still my basic default format of teaching is Hindi. So I might switch over to Hindi for a few sentences during the course of the lecture. So please forgive me for that. I hope it's not like I hope there are not some people who can't understand Hindi at all. If there are, then please write in the chat box. Lastly, I will not go for fact-based learning. What is fact-based learning? Fact-based learning is like you learn everywhere else, like you learn on YouTube, like you learn in so many conferences. What people do is they write the textbook on the slide, they read it out, they recite some fact which you don't know, and you believe that yes, I didn't know that and now I learned that. So this is fact-based learning. There is another kind of learning which is concept-based learning, where I teach you a simple formula, and by that formula you can deduce many more things. So I'll try to make this class more about concept-based learning rather than fact-based learning. So like as an example for fact-based learning, we all know that fact-based learning is like, I have put a slide, this a patient has a pH of 7.40, he has acidosis, alkalosis, kuch bhi nahi hai, kuch bhi ho sakta hai. Just write down, write in the chat box. Right. So again, what you are answering is from the fact-based learning you have had. Similarly, fact-based learning is that we know that the causes of high anion gap acidosis are mud piles. When an ABG comes to you, you never go by mud piles. I bet none of you has ever actually thought about mud piles except for exams. Nobody looks, is it paraldehyde poisoning or is it ethylene glycol poisoning? Nobody does it. It is a fact-based learning. Similarly, I'll again put a question to you. It is again fact-based learning. What is the normal pH? Tell me. Oops, I made it bold already. Oh, गड़बड़ हो गई. चलो कोई बात नहीं. Well, that is the problem with fact-based learning. I ask the normal pH of a cell. In a cell, the environment is slightly acidic or borderline neutral. The pH inside of a cell is not 7.35. It is a little less than 7 or just around 7. That is the problem with fact-based learning, because you learn, you wrote, and whenever you see something, you just jump onto the answer. So just keep your eyes and ears open and we'll learn a lot. Again, fact-based learning, these are all normal values, you all know them. I hope there is nothing to teach in them. One interesting point in all these values is the number 4. If you want to remember something, just remember the average pH is 7.40. Whenever you are doing a calculation, it will be from 7.40. PO2 8200, that's fine. PCO2 normal 40. Bicarbonate 2424. Sodium 140, potassium 4, chloride 104. The prevalence of number 4 is staggering. Just remember the normal values. We'll come to the questions. Again, another question. Is this ABG normal? I'll just stay away from the screen. So we'll do it as a quiz, but all the while you'll keep learning. Chat box. Is this ABG normal? Hey, I'll ask screen coordinators to just keep looking at answers and find the people who are interacting the most and the people who answer the difficult questions first. We'll give some prizes. Right. So everybody is writing because they know the normal values. I already told them in the previous slide, and these values are normal. Did I tell you that this patient is on ventilator with FiO2 100? Would anybody like to change their answers now? This patient is on ventilator and the FiO2 is 100. Is this ABG normal? No, it is hypoxic. So when you say that the normal value of PaO2 is 80 to 100, it is not normal 80 to 100. There is one caveat. It is normal for a FiO2 of 21%. The PaO2 of 80 to 100 is normal, but it is normal for an FiO2 of room air. On ventilator, on oxygen, on a mask, the PaO2's normal value should be 5 times of FiO2. These golden frames are something to be noted down or something to be taken a screenshot from. The normal value of PaO2 should be 5 times of FiO2. If it is less than twice FiO2, then the problem is severe. Then the patient must be in severe ARDS. For FiO2 100, the PaO2 should be 500. So the golden word is never comment on an ABG until you know the FiO2. If you are practicing in an ICU or you have sent an ABG, or if you have just got an ABG to read, always ask, what is the patient on? What is the oxygenation of this patient? Is he on room air? Is he on a mask? Is he on a ventilator? What is his oxygenation status?
Arena, you
Never
have to be
comment on
active and sir will
ABG
be
till you
talking
know the
like
FiO2.
what choices have come in the box and all that time you should be.
Excuse me? Anyway, see. So never comment on an ABG until you know the FiO2. If you are sending a ABG, then write the FiO2. If you are receiving an ABG, then ask for FiO2. Ask your nurses in the ICU to comment on FiO2. Similarly, again, let's talk about oxygenation and ventilation first, then we'll jump to acid base. Similarly, what is this? Is it ABG or is it VBG? Write down, is it ABG or VBG? Again.
For VBG, maximum answers.
No, ma'am, I'm seeing the chat box all the time.
Yeah.
Right. But I never told you that this patient has a saturation of 70. Now, is it ABG or VBG? Now, it could be any of those. Again, whenever you see an ABG, first ask what is the FiO2 and what is the saturation on monitor. Saturation on monitor is one of the best tests to diagnose ABG versus VBG, because if your saturation in ABG is coming to be like 70 and the saturation on monitor is 95, then it is definitely a VBG. But if the saturation on monitor is 70 and the saturation in the report is 70, then it could be either ABG or VBG. It is very difficult to know. There are things, the CO2 थोड़ी सी ऊपर नीचे and pH थोड़ी सी कम ज़्यादा, but it's difficult. The best test to diagnose an ABG from VBG is to look at the monitor and look at the saturation. So two things we learned in this 5-10 minutes is, one, never comment on an ABG until you know the FiO2 or the oxygenation of the patient. Never comment on an ABG until you know the saturation on the monitor. Why can't you trust the saturation in the ABG report? Can somebody tell me how many things? Now this is a question for a prize. This is not an MCQ. Can somebody tell me how many things are measured in an ABG? What are those things? Write in the chat box. एक ABG मशीन क्या क्या measure करती है? You can write the number, you can write the things. No, it doesn't measure anion gap. The pure ABG is this pH, PCO2 and all. Electrolytes are not exactly part of ABG. Good. I am seeing only 4. That's good. That's good. That's good. That's good. If I have to choose, थोड़ा सा scroll करना. An ABG machine measures. Look, note the word measures. Only 3 things: pH, PO2, and PCO2. Even the bicarbonate value, the saturation value, the base excess value, everything is calculated from these 3 numbers. Of course, I'm not counting lactate and electrolytes and everything. The pure pH, the pure ABG thing has 6 things. Hai na? pH, PO2, PCO2, bicarbonate, and your base excess. Out of these things, only 3 things, pH, PO2, and PCO2 are measured. Even the saturation is calculated, unless until some very advanced machines have co-oximeter which actually measures the saturation. Otherwise, this SO2 is extrapolated from PO2. So the saturation in ABG report is bakwas. Let's check another thing. What is your PaO2 right now? All of you people sitting in your homes comfortably breathing. What should be your PaO2 right now? Write down. Good, good, good. 80 to 100, 80 to 100. We are all breathing room air. And what must be your saturation? Your saturation would be 98 to 100, 98, 99, 100. Right, fair enough. What if I put you on a nasal prongs? What will happen to your PaO2? It will increase. If I put you on nasal prongs, your PaO2 will increase. Your saturation will increase. Right now it is 98, it will become 100. What if I put you on oxygen by a mask, say NRBM, 80% oxygen? Your PaO2 will increase. Your saturation will? Your saturation will increase 100. Okay, leave everything. What if I put, don't take it personally. What if I put you on a ventilator with 100% FiO2? Your PaO2 will increase further. but your saturation will remain fixed, 100. So what does a saturation of 100 show? It shows nothing, it is useless. It shows that the PaO2 can be 100, PaO2 can be 200, PaO2 can be 500. A saturation of 100 is the most useless thing. That is one thing that killed a lot of patients in COVID, because people targeted a saturation of 100. They put 3 types of oxygen, nasal prong bhi laga do, and mask bhi laga do, and NRBM bhi laga do, and BiPAP bhi laga do. They targeted a saturation of 100. The PaO2 initially would be like 300, then it will drop to 200, then it will drop to 100, and eventually the things will start coming to the notice only when the saturation fell below 100. So a PaO2 from 100 to 500 will give a saturation of 100 only. Below that, every saturation has a number of PaO2. This I want you to remember. So if somebody has a saturation of 100%, you only one thing, that his PaO2 is from 100 to 500, any number. But if somebody has a saturation of 94%, his PaO2 should be approximately 80%. These numbers are approximations. If somebody has a saturation of 90, it should be 60. So by looking at the saturation on the monitor, you can predict what would be his PaO2. And conversely, looking at the PaO2, you should be able to guess what would be the saturation of this person. Right? Also, your target on any kind of oxygenation device, NRBM or mask or ventilator, should be a saturation of 94%, not 100%. You should target a saturation of 94%. The beauty of this is that when you see a saturation of 94%, you already know the PaO2 of patient. Like I asked you in the previous question, if your saturation is 100, your PaO2 could be anything from this number. But if a saturation is 94%, the PaO2 will be in this range only. And if your saturation is falling, then you can know that something is going wrong. What if somebody has a low PaO2? There can be only 2 causes. One of them is either he is not getting enough oxygen, the FiO2 is less, or there is a problem with the alveolo-capillary membrane. If somebody has a low PaO2, there can be only 2 things. Either he is not getting enough oxygen, or his alveolo-capillary membrane is blocked. It could be blocked by pus, you can say pneumonia. It could be blocked by water, you can say pulmonary edema. It could be blocked by anything, thickening. And there are only 2 solutions of a low PaO2. One is increase the FiO2, and second is, just write down, wonderful. Likh lena bhai. The first is increase the FiO2, and the second one is to give PEEP. So the golden words are aim for a saturation of 94% only, and if there is a low PaO2 problem, you can only do 2 things, increase the FiO2 and increase the PEEP. So this was about oxygenation in ABG. Let's talk about CO2. This you all know, this is fact-based learning. CO2 is produced in body by metabolism, removed by ventilation. PCO2 in blood depends upon only one thing. And that one thing is, if I measure my PCO2 right now, it depends upon only one thing. And what is that thing? What is that one thing? Breathing, yes, breathing is more generic answer. Anesthesia PG should be writing minute ventilation. I would actually expect a better answer, but I'll accept ventilation as an answer. So PCO2 depends on only one thing, and that is minute ventilation, and that is respiratory rate into tidal volume. Again, golden words coming, take a screenshot. A ventilator has only 2 types of button. One is PaO2 button and the other is PCO2 buttons. A ventilator has only 2 sets of buttons. One is oxygen buttons and the other is CO2 buttons. The oxygen buttons are PEEP and FiO2, and the CO2 buttons are respiratory rate and tidal volume. Remaining everything is practically useless. So if you can manage these four things, you can manage CO2 and O2. So PaO2 we have discussed, PCO2 we have started discussing. Now you tell me another thing. There are two patients, patient A and patient B. Which one will have a higher PCO2? Again, I'll expect your answers. Patient A is having a respiratory rate of 15 and tidal volume of 400. So minute ventilation of 15 fours are 6 liters. He is comfortable in sitting. The other one has a 500 into 20. So that is a 10 liter minute ventilation and he is dyspneic and tachypneic. Which one will have higher PCO2? So it appears that the person who is hyperventilating should have logically a higher PCO2. But again, it is a myth. There is no clinical parameter that can predict the PCO2. The PCO2 can be predicted only by ABG. Maybe, if you are in OT, then you can predict by ETCO2. But in real life, there is no clinical parameter, no respiratory rate and no tidal volume can guarantee a PCO2 washout. So whenever you see a patient, he is dyspneic, he is tachypneic, don't expect that he is having a PCO2 of 25. He might not be. He might be failing in his ventilation and he might be having a borderline higher PCO2. So there is no clinical parameter that can predict the PCO2. Again, that was one problem that we faced during COVID times again. Let's say a patient is very tachypneic and he's hyperventilating and you get his ABG and his PCO2 is like 40. His PCO2 is normal and the patient is breathing like mad. So would you say that his PCO2 is normal, he is ventilating adequately? No, probably not. The person who is generating a minute volume of like 15 liters per minute should have a PCO2 of 25, 28. If he's having a PCO2 of 40, then probably he's on the downhill course. So never predict PCO2 from clinical picture and never predict clinical picture from an ABG report. Combine those two. So यहाँ तक की अपनी story was about PaO2 and PCO2. So far so good. अभी तक का समझ में आया हो तो chat box में yes sir लिख दें. Then we'll move to acid base balance. ठीक. चलिए. So let's move to acid base balance. Again, it is a PG quiz. I'll keep asking questions and I'll keep busting the common myths. This is an ABG. This looks normal. Normal है कि नहीं है? भाई तुम तो chat box लगाए रखो. पूछता ही रहूँगा. Normal है ना? ठीक है, fine. Now, what if? Again, it is theoretical question. It is physiologically not possible. But what if I increase the PCO2 to 80 and bicarbonate to 48? Both are increased. What will be the new pH? और आपके options ये रहे आपके screen पर. थोड़ा सा पानी दे दो ना यार. हाँ ये दे. हाँ जी, 1-2 D भी है, पता नहीं, इज अ वेरी गुड आंसर. सेम भी आ रहे हैं कुछ के D भी आ रहे हैं. चलिए, तो अगेन दिस इज अ फैक्ट बेस्ड लर्निंग. हटा दो. फैक्ट बेस्ड लर्निंग क्या, व्हाट इट सेज इज If pH is low, then it is acidosis. If pH is high, then it is alkalosis. pH is normal, then everything is normal. Bicarbonate is the metabolic component, and carbon dioxide is the respiratory component. You all know that. Before sitting into this class, you all know that. Now, if I ask you, again chat box, if I ask you what is pH, what will you write? What is pH? A little more, a little more. That is the full form of pH, you can say. What is exactly pH? Okay, potential power, ठीक है. What I was expecting was something like this, कि pH is 6.1 into log so and so, blah blah blah. This upon that. नहीं समझ में आया. Even I didn't understand anything. This is complicated. Let's try something simpler. Now I'll teach you pH in my particular way, and then you'll come back to me. There are two things. There are two suffixes. One is called as osis, and the other one is called as emia. Osis and emia. I will define osis as a desire, a hasrat, a chah, a want. I want to do this. And emia is what actually happened. Right? Osis is want. Emia is happened. So there are two kind of forces in your body. One are blue forces. You know litmus paper. Blue is alkaline and red is acidic. So there are blue forces which are alkaline, and there are red forces which are acidic. And they are constantly in a war. The red forces are acidic and they want to make the pH of the blood acidic. So they want acidosis, they create acidosis. Similarly, these blue forces, the bicarbonates, they want alkalosis. They want to increase the pH. The want is osis. But what happens is the net result. It might be acidemia, it might be alkalemia, and it might be a normal pH, a neutral pH as you call it. So there are two kinds of forces. One is CO2, which is acidic, which is respiratory acid. CO2 is a respiratory acid. And bicarbonate is a metabolic alkali. They are fighting and they have equal power. I am not saying they are equal in number. CO2 is 40 normal and bicarb is 24 normal. They don't have equal number, but they have equal power. And they are in a tug of war, and they balance off each other, and by balancing off, they maintain a neutral pH. So CO2 causes acidosis. Increase in CO2 causes acidosis, increase in bicarb causes alkalosis, but the final result will depend upon the relative power of these two. ये समझ में आया कि नहीं आया? Did you get it? Again, I'll repeat. PCO2 wants a acidotic pH. Bicarbonate wants an alkalotic pH. They want, it is acidosis and alkalosis. Acidosis, alkalosis, osis is a want. But what happens? Acidemia, alkalemia, or a normal pH is the result between the is a result of the fight between these two. Now, did you get it? If you got it, just tell me. Then I'll move to the next part. Right, repeat. Chat hटा दो. So, actually chat is for my thing. So, there are two kind of forces. One force wants acidosis. That force is bicarbonate. The force that wants alkalosis is bicarbonate. The force that wants acidosis is carbon dioxide. Now, the final pH is not dependent upon carbon dioxide. It is not dependent on bicarb either. It is dependent on the proportion of the two, the relative strength of the two, the result of the fight between the two. You will understand it more with the coming example. Let's say there are 4 wrestlers from the blue side who want alkalosis, and 4 wrestlers from the red side, that is acidosis. Now what will happen? You will tell me what will happen if 2 wrestlers increase on the red side. The power on the red side will increase, the strength on the red side will increase. The red side is acidotic, and this strength will cause the pH to become more red, that is more acidotic. So this will result in what? Acidosis or alkalosis? Write down. Just show me for a second. Yes. Right. ठीक है. So the red side increased in number and there is acidosis. This acidosis is because the power of the acidic side is increased. This acidosis is purely because of respiratory causes. This acidosis is because maybe somebody consumed a lot of opioid. Maybe someone got hit on the head by a baseball bat. He is unconscious, he is not breathing properly, his CO2 is increasing, he is going into CO2 narcosis, he is retaining his breath and he is getting acidotic. This acidosis is metabolic or respiratory? This is purely because of respiratory causes. The pH is moved towards pink side and this is respiratory acidosis. Why respiratory? Because it is because of CO2. It has nothing to do with bicarbonate. Bicarbonates are there. They are equal in number. They are as before. They haven't increased. They haven't decreased. They are as before. But CO2 has increased and it has caused the pH to pull towards red side, and this is respiratory acidosis. एक second chat box दिखाओ. Right, this is respiratory acidosis. Next example. हटा दो. Again, everything was same. PCO2 was normal, bicarbonate was normal. The previous patient who was consuming opioid or who was hit by a bat in his head, now he was put on ventilator and we gave a lot of tidal volume and a lot of minute volume. Eventually, he washed off his CO2. His CO2 decreased. Now what will happen? Now which side is stronger? Blue side or red side? Just write down simply blue or red. Blue side is stronger. Is it because the bicarbonates increased? No, the bicarbonates are as before. The bicarbonates are not changing. It has nothing to do with bicarb. It is going towards alkalotic side. The pH is going towards blue, but not because bicarbonates have become stronger, because they have become relatively stronger. Focus on the word relative, proportionately more. So CO2 has decreased in proportion, and that is why bicarbonates are not more in number, they are proportionately more in number. So again, this is alkalosis, but not because of bicarbonate, but because of CO2, but because of respiratory causes. So this is alkalosis, but respiratory alkalosis. Why respiratory? Because bicarb had nothing to do in this. In the previous example and in this example, bicarbonates have just held their ground with their 4 members. In first example, CO2 increased by 2. In the second example, CO2 decreased by 2. But the bicarbonates remained constant. So in previous example, the acidosis was because of CO2. In this example, the alkalosis is also because of CO2. So previously it was respiratory acidosis, now it is respiratory alkalosis. समझ में आया? आया हो तो लिखो आया. ठीक है. बस चलेगा. ठीक है. Then same example again. Now there was a problem. This person was given diuretic, a lot of diuretic, and he started holding on to bicarbonate. His bicarbonate increased from 24 to 26 or 28. Now this guy has increased bicarbonate. Which side will get stronger? Blue or red? There is no point in even writing, you know that. Blue side is stronger. So blue side is acidic or alkaline? The blue side is alkaline. So what will happen? Acidosis or alkalosis? Alkalosis. Why is this alkalosis happening? Is it because of CO2? Does it have anything to do with respiration? No. It has everything to do with metabolic causes. So this is metabolic alkalosis. Got it? This time bicarbonates have increased. Everything has to do with the metabolic thing. So this is metabolic alkalosis. Last point. Bicarbs were there, but due to some reasons, 2 bicarbs were martyred. 2 bicarbs we lost somehow. There are 2 reasons to lose bicarbs. One is they go and fight some external acid, and the other is the kidney or the gut loses bicarbs. So one way or another, we lost half of our bicarbs. So the bicarb side became weaker. Who will become stronger? CO2. Has it increased? No, it hasn't. It is the same. It is just holding its ground, but now it is proportionately more than bicarbonate. So CO2 will be able to pull the pH towards its red side, and this will be a acidosis. But what acidosis is it? Has it become acidotic because of the CO2? No, this has become acidotic because of loss of bicarbonate. So the cause lies in metabolic side. So what is this? What is the diagnosis? What is it? This is metabolic acidosis. Good. ठीक है. So you got the concept. This was different from your fact-based learning. What did you learn? You learned that the pH is not about bicarb or CO2. It is about their relative strength. Let's play it. Let's play it. Then we'll see. So now don't try to do it with your previous learning. Try to de-learn a bit and just think which of the 2 sides is stronger. You know the normal values. Bicarb should have been 24 and CO2 should have been 40. So which of the side, just imagine in your head कि red side is stronger or blue side is stronger. Which side is stronger? Red side is stronger, PCO2 side. And coincidentally, the pH is also acidic. So red side of CO2 is stronger because of CO2 and pH is acidic. What should this be? देखो, what should this be? This is respiratory acidosis. So don't think, how do we do it? How do we do it? What we do is कि, okay, pH is there and the direction of change of this is in this. Let's do it differently. In this case, pH is 7.5, PCO2 is 28 and bicarb is 24. So bicarbonate, the blue side looks as it was, 24, normal, near normal. The PCO2 side looks half. The PCO2 side has gone weaker. Probably 2 red wrestlers have gone away and the pH has become blue. What is this? Respiratory alkalosis. Complicated pe bhi aayenge. Let's do simple first. This one, what does it look like? Think in my way. It's not about diagnosing. These are easy to diagnose. Anybody can diagnose them. But think how I want you to think. pH is, don't look at pH. This side is weaker, should have been 24, it is 18, definitely less. This side is near normal, a little less. This is acidic. This should be weakening of blue. So acidosis because of blue side, metabolic acidosis. Wonderful. Everybody is answering correctly. So either you know it beforehand or maybe I'm teaching good. pH is on the blue side. PCO2 looks on the normal side and bicarb is on the increased side. Again, I'm saying, just imagine the previous animations and think in those terms. Which side is stronger, blue or red? Blue side is stronger, and if blue side is stronger, then it is metabolic alkalosis. So now, now this equation makes more sense. What it wants to say is that pH is ultimately about the ratio between bicarb and CO2. The more the bicarb will increase, the more the pH will increase and the patient will become alkalotic. The more CO2 will increase, since it is inversely proportional, the patient will become more and more acidotic. And inversely, if the bicarb will decrease, the pH will decrease. If CO2 will decrease, the pH will increase. So coming back to the previous question, now you can all answer it correctly, although somehow I have written the answer. So what we have done here is, we have increased the CO2 to twice and we have increased the bicarbonate to twice. So what will happen to this patient? Again, this is a hypothetical question. This will not happen in real life. But theoretically, the pH will remain same. How come? There are 4 and 4 wrestlers on each side. What we have done is, we have increased 2 wrestlers on each side. So eventually the pH will be neutral. This is very important to learn the concept of compensation. So now we know what will happen if we increase the PCO2 and increase the bicarb by same proportion, not same number. The pH will remain neutral. Now let's understand compensation again in a conceptual way. So this patient was apparently all right, everything was fine. And he got, let's say, he got sepsis. Because of sepsis, he became acidotic. By sepsis, he lost his bicarbonates. He lost 2 bicarbonates. His bicarbonates have become half. Now what will happen? He's in sepsis, you know that he'll be having metabolic acidosis. Now, body always likes a neutral pH. Body will try very hard to maintain a neutral pH. To maintain a neutral pH, it will do whatever is in its power. So if this equation has imbalanced to one side, the body can do only 2 things. Either it can bring back 2 bicarbonates, but that is the primary problem na bhai. Bicarbonate is lost. Otherwise, this wouldn't have happened in the first place. So the only thing the body can do in case of a metabolic acidosis is to reduce the 2 wrestlers from CO2 side also. Then it should become normalized. So the concept of compensation is, the compensation should be or is equal and opposite. So if bicarbonate is lost, the body will try to lose CO2 also. Getting it? If 2 bicarbonates are gained, if there is a metabolic alkalosis, if there are 2 additional bicarbonates, then body will try to gather some CO2. The body will start retaining CO2 to compensate for that. Conversely, if the body has collected a lot of CO2, the same body will try to accumulate bicarbonates. If body has lost CO2, then it will try to lose bicarbonates. So the compensation should be equal and opposite. Did you get the concept of compensation? Compensation means if the body has lost bicarbonates, so it cannot gain back automatically unless you give it from outside, that is a different thing. But unless the body cannot generate bicarbonates, it is losing it as such. So the only thing it can do is, it can lose proportionate amount of CO2 to keep the pH neutral. This is what is happening. This is a compensated metabolic acidosis. The ABG will look like something, the pH will be a little on the acidic side, because the compensation can never be overcompensation. The compensation can never be too much compensation, that if there is an acidosis and the compensation will cause it to become alkalosis, no, it will never happen. The compensation will always be partial, a little less than normal. So a compensated metabolic acidosis will look like, the pH will be a little less than 7.4, the bicarbonate will definitely be less, that is the primary problem, and the CO2 will be washed off. And this is partially compensated metabolic acidosis. How do you know? did you get the compensation part? If not, then I can repeat. Clear, na? Respiratory compensation by losing CO2. True. Wonderful. Got it? Got it? Everybody got it? Fine. Chal, padhiya. So how do you know that this compensation is adequate? There is a formula in the fact-based learning method. How to check if the compensation is adequate? In metabolic acidosis, bicarbonate goes down and body washes off CO2, so CO2 should also go down. What will be the next CO2 can be calculated by Winter's formula. The expected PCO2 will be 1.5 into bicarb plus 8. So in the previous ABG, this was it, and then this was it. This is difficult. If you want to learn for examination, just take a screenshot of this and you'll know. I'll teach you a jugaad for this. You got it? Whenever body is having metabolic acidosis, it will try to lose CO2. Now what should be the new CO2 is decided by Winter's formula. I will tell you an easier method. In metabolic acidosis, the PCO2 should be equal to last 2 digits of pH. Again, I'll slow down. A patient is having metabolic acidosis. His pH is less than 7.4. Let's say it is 7.35. So his PCO2 should be 35. The pH is 7.30. His PCO2 should be 30. The pH is 7.32. His CO2 should be 32. So the last 2 digits of pH should be roughly, don't take it like a gospel truth. It is the last 2 digits of pH should be equal to CO2 in metabolic acidosis. So if the pH is 7.32, the PCO2 should be 32. If the pH is 7.25, the PCO2 should be 25. If the pH is 7.15, the PCO2 should be, the pH is 7.15, the PCO2 should be 15. Wonderful. Shabas. एक नहीं लिखा? नहीं और नहीं लिखा. ठीक है. What now? Chat box फिर से. What if the pH is 7.0? Not 100. So, ठीक हटा दो. This formula works up to 7.15. Beyond that, it is already difficult. But then they say that it is difficult to maintain a CO2 less than 10 or 15. You can wash off your CO2, you can hyperventilate as much as you want, but you cannot make CO2 in your blood to 0. You can bring it down to 10, 15, but I don't think anybody has seen a less than 10 PCO2. So let's say this formula works till 7.15. If the PCO2 is 15, then your compensation is adequate. If the PCO2 is like 35 right now, then there is an additional respiratory acidosis going on. That is why I'm telling you this formula. If the pH is 7.25, the PCO2 should be 25. What if it is 35? There is additional respiratory acidosis. That is a mixed disorder. Okay? So this again the golden words in metabolic acidosis, PCO2 should be equal to last 2 digits of pH. Okay? So metabolic acidosis you understood how compensation occurs in metabolic acidosis, how much CO2 should be washed off. Now let's come to respiratory acidosis. Again, I won't be teaching alkalosis. Let's come to respiratory acidosis. In respiratory acidosis, CO2 is increased because of whatever reason, and opioid overdose or whatever. What will happen? The body will try to increase bicarbonate, to retain bicarbonate, to hold on to bicarbonate. But then Respiratory compensation is quick. The moment your pH drops, you will start hyperventilating. But metabolic compensation doesn't occur in a minute. A little happens, buffering occurs, but not more than that. Metabolic compensation takes time. It takes 2-3 days to occur. But then metabolic compensation is solid. It compensates for the pH, it compensates for everything. So a respiratory compensation is never perfect, but a metabolic compensation is way better than a respiratory compensation for metabolic acidosis. So a patient is having respiratory acidosis acutely. He was perfectly fine, he got hit on the head and he is holding his breath. So the body will try to retain bicarb, but initially maybe the bicarb will increase by 1. 24 normal, 25, not more than that. But over a period of 3, 4, 5 days, the kidneys will take over and they will retain more and more bicarbonate, and eventually the bicarbonate will equalize or try to normalize the pH as much as possible. So the previous one was acute compensation, the compensation for acute respiratory acidosis, and when it becomes chronic respiratory acidosis, the compensation will be adequate. Like in COPD patients or in bariatric patients, the respiratory acidosis is compensated adequately. That is called as chronic respiratory acidosis. How much should be the compensation? In a patient with respiratory acidosis, in acute respiratory acidosis, somebody has a CO2 suddenly of 60, then the bicarb will increase by maybe 1 or 2 for each 10 rise in CO2. I'll repeat. The PCO2 is 40, it has become 50. The CO2 has increased by 10, so bicarb will increase by 1. That is acute respiratory acidosis. So in an acute respiratory acidosis patient, you will find a PCO2 of 50 and bicarb will be 25. PCO2 of 60, bicarb will be 26, not more than that. In chronic respiratory acidosis, 4 bicarbs will increase for each 10 rise in CO2. Again, I'll explain. If CO2 increases from 40 to 50, the bicarb will become 24 say 28. I'll repeat. Forget acute. In chronic respiratory acidosis, for each rise, each 10 points rise in CO2, the bicarb will increase by 4. If CO2 increases from 40 to 50, the bicarb will become 28 from 24. They will rise by 4. What if the CO2 increases from 40 to 60? What will be the new bicarb? What will be the new bicarb? Tell me. ठीक है, 28 to 32. If CO2 is 70, then what will be the bicarb? If CO2 has become 70, what will be the bicarb? 36. If CO2 is 80, then bicarb should be how much? If CO2 is 80, मैं chronic की बात कर रहा हूँ, I'm talking about chronic respiratory acidosis. If CO2 is 80, then bicarb should be 40. This is compensation. This is somebody who has a CO2 of 80 all the time, somebody who has a CO2 of 60 all the time. This is chronic respiratory acidosis. So you're getting this. You got this 4 bicarb for 10 CO2. If you haven't got it, then you won't be able to understand next concept. Tell me if you have got it. आया? ठीक है, ठीक है, ठीक है, ठीक है, ठीक है, ठीक है, बढ़िया. So now my question to you is, there are 2 ladies in the ICU. Both are unconscious. Which one has acute respiratory acidosis? Or maybe let me change the question. Which one has CO2 narcosis? Both are unconscious. Which one? Young and old you can write. There are 2 patients in the ICU. Both are unconscious. Which one has CO2 narcosis? Well, actually, we don't know because we don't know the CO2 of both patients. Okay, let me tell you the CO2 of both patients. The CO2 of both the patients is 80. Now, which one has CO2 narcosis? Both are unconscious, young and old. It's not about the age, I'm talking about ABG only. Which one has CO2 narcosis? We don't know. Okay, let me tell you one more thing. The older lady has a pH of 7.30 and a bicarb of 36. The younger one has pH of 7.12 and bicarb of 26. Right? Now think in terms of what I taught you 3 minutes back. What should have been the baseline CO2 of the older lady? I taught you, if the CO2 increases from 40 to 50, the bicarb should be 28. A person with CO2 40 should have a bicarb of 24. A person with a CO2 of 50 should have a bicarb of 28. A person with PCO2 60 should have a bicarb of 32. A person with PCO2 70 should have a bicarb of 36. Chat box चलने दो ना. So somebody who has a bicarb of 36, both have come to the hospital, you don't know anything about them. Somebody who has a bicarb of 36 at a random sample must be having a chronic compensation. She must be having a baseline CO2 of at least 70. So she knows how to survive at a CO2 of 70. She is chronically respiratory acidotic. It is compensated. So it has increased only by 10. Probably this rise of 10 will never cause her to go into CO2 narcosis. Are you getting my point? In this case, she has gone into severe acidosis. There is not much of a compensation from bicarbonate side, and her CO2 has gone 80. Probably she has gone into CO2 narcosis, and she is more like a compensated respiratory acidosis. Her cause of unconsciousness should be something else. Most likely it is not CO2 narcosis. Most likely it is CO2 narcosis. Do you agree with me or not? You got my point? Right. Skipped. Okay, fine. I'll explain again. I told you 2 slides earlier that for every chronic rise of 10 points of CO2, chat box hटा दे, for every chronic rise of 10 points of CO2, the bicarbonate should increase by 4. So if the CO2 normal is 40, bicarbonate is 24. CO2 goes from 40 to 50, bicarbonate should become 28 to compensate ना, दोनों साइड बराबर. CO2 goes from 50 to 60, bicarbonate should go from 28 to 32. CO2 70, bicarb 36. CO2 80, bicarb 40. So somebody, now I'm reversing the situation, somebody who has a bicarb of 36 should have a CO2 of 70. Now somebody who has a baseline CO2 of 70, if she increases the CO2 to 80, there is nothing extraordinary happening here. It might be happening in her sleep also. So if she's unconscious, it could be something totally different. But somebody who is young and has a severe respiratory acidosis and there is no metabolic compensation, she is probably in acute respiratory acidosis and a PCO2 of 80, must be having CO2 narcosis. Now did you get it? So the point is, always check bicarbonate before commenting on respiratory acidosis. If the PCO2 is 60, and bicarbonate is 25 or 26, then you know it is acute respiratory acidosis. If for the same PCO2 of 60, the bicarbonate is 31, 32, then it is chronic respiratory acidosis. Got it? If for the same PCO2, the bicarbonate is a little higher side, acute respiratory acidosis. If bicarbonate is proportionately 10, 4, 10, 4, if the bicarbonate is 4 high for each 10 CO2, then it is chronic respiratory acidosis. So far so good? आगे चले? चलिए. So again, a question for you. Does this patient have acidosis or alkalosis? चलो हटा दो. So just try to remember this ABG. I'll show it to you again after the next concept. So we are coming to the let's say like 20-25 minutes remaining in the webinar. Again, a very important concept. Just focus. What is the first thing you check in an ABG? Again, question. Write down. ठीक है. So till date what we were doing is हटा दो. Till date what we were doing is we were checking the pH and PCO2. This is the traditional method. We do it all the time. We checked for pH and PCO2. If the pH was low, then it is acidosis. If it was higher, then it is alkalosis. Fine. Then we'll see if they are both in the same direction and blah blah blah. Then we'll check for bicarbonate. We'll apply Winter's formula. Then we'll check anion gap. Then we'll check delta gap strong, and by then we'll be completely lost. Today we will reverse how to approach an ABG. We will learn ABG ulta, not ulta like this, but in a different approach. What will be the ulta approach? The first thing we will see in an ABG will be anion gap, which you never looked at. The first thing we will see in the ABG is anion gap. Then we will look for base excess. Then we will look for pH, PCO2 and bicarbonate. Right? करके देखते हैं. What is anion gap? Can somebody write in the chat box? Because the screen coordinators are watching, they are looking for prizes to be given. What is anion gap? ठीक है, बढ़िया, बढ़िया, बढ़िया. ठीक है. Right. So there are various cations or positively charged ions and equal number of anions. Now, like they say, body loves neutral pH. Body tries to compensate whenever there is acidosis or alkalosis. But the same body loves electroneutrality even more. What is electroneutrality? The total charge should be neutral. The total charge should be zero. The positive charge should be equal to negative charge. The total charge of cations and anions should always be equal. नहीं समझा तो. Now this is a balance. It should be equal. This is a balance. What you call balance in तराजू. So on one side there are cations and on the other side there are anions. The anions are, what are the anions? नहीं यार, देखते हैं. The major cation is sodium. We will forget potassium from this calculation. वैसे भी 4 होता है. The major cation is sodium. It is 140, 140. The major anion is, write in the chat box, screen coordinators please note. What is the main anion in the body? Basic सवाल. शाबाश, very good. ठीक है, जो भी पहला था देख लेना. The major anion that balances this is chloride. The second anion that balances it is bicarbonate. So now this equation is balanced. The both sides are equal. Are they? Are they equal? No, they are not equal. There is a difference between the both the sides. What is the difference? 128, 140. How much is the difference? 12. Chat box दिखा ना. हाँ, what is the difference? 12. 122 नहीं है. हाँ, 12. Right. What is the difference? 12. ये 12 कहाँ से आया? This 12 is unmeasured. It is there, just that we don't have enough resources to measure it. In a routine ABG, we can measure sodium, we can measure bicarb, we can measure chloride. This unmeasured is there, but it is hidden. It is hidden behind a wheel. It is छुपा हुआ behind a घूंघट. It is not दिख रहा. It is not visible, but it is there. It has to be there to make the equation balance. 4 plus 4 plus 2, 10, 0, 1, 1, 2, into 4, 1, 4, 0, 1, 4, 0. So these 12 anions which we cannot see, they are made up of sulfate and proteins and organic acids. They are unmeasured. But this unmeasured anion is called as anion gap. So we are all clear on what is anion gap. Now let's try to understand another concept. What will happen if external acid attacks your body? Let's say you give your patient an injection of hydrochloric acid, your sulfuric acid. Don't do that, just theoretically. What if you give an external acid to your patient, something like sulfuric acid? The sulfuric acid molecules will run, like, let's say 5 soldiers will come or 4 soldiers will come, and they will attack the body. They will try to decrease the pH. What will happen? Body will send 1 bicarbonate for each unmeasured external acid. I will repeat. Let's say there are 4 molecules of sulfuric acid coming. Those sulfuric acids will release H ions, right? Let's not talk about valency here. Let's consider it a single valency only. H2SO4 was injected. 4 molecules of H2SO4, they brought 4 H ions. Now body is very much afraid of H ions. It will quickly send 4 bicarbonates, and those 4 bicarbonates will hold 1 H ion. Again, I'll repeat. 4 H2SO4 came in. Those 4 H2SO4s released 4 H ions, and those 4 H ions were balanced by 4 bicarbonates. For every external H ion, 1 bicarbonate was sent. And that bicarbonate was like a suicide bomber. It goes to the H ion, it combines with the H ion, it diminishes. So 1 bicarbonate is lost trying to conquer each external H ion. Aaya samajh mein? Or should I repeat? HCO3 Shahid, that is the exact word. Right? So body loses 1 bicarbonate for every external H ion that is coming to attack you. So let's consider this on this taraju. This is the normal situation. Now 10 unmeasured red colored soldiers attacked. What will happen? To counter them, these bicarbs will send 10 soldiers to balance this H ions. So bicarb will decrease from 24 to 14. Do you get it? 10 external H ions came, 10 acids came. The H ion was neutralized by 10 bicarbonates, and the remaining 10 external acids stayed unmeasured. Bicarbonate has decreased from 24 to 14. Why? Because 10 bicarbonates got Shahid fighting to the external acids H ions. The external acids anions remain in the system as unmeasured anions. So now when we try to calculate anion gap, it comes to be 140 minus 104 plus 14. Kitna aega? Calculate it. So now if we try to subtract bicarb plus chloride from sodium, what will be the answer? 22. This 22 is what? This is anion gap. What is anion gap? It is nothing but the unmeasured acid. Now we cannot measure sulfuric acid, we cannot measure nitric acid. So if an external acid like lactic acid or like diabetic ketoacidosis ka acid, if any of these outside acids come in your body loses equal amount of bicarbonate to fight those. And this bicarbonate is decreased, but the outside acid anion, which is unmeasured, remains hidden, and this looks like a gap, a big gap between anions and cations, and that is called as increased anion gap. Right? How to calculate anion gap? Sodium minus chloride plus bicarbonate. Normally it is 12. If it is more than 15 or something, then it is anion gap. So based on anion gap acidosis, there are two types of anion gap acidosis. One is called as NAGMA and the other one is high anion gap metabolic acidosis. ठीक है? If anion gap is increased, then it is high anion gap metabolic acidosis. If anion gap is normal, then it is normal anion gap metabolic acidosis. Now look at these three ABGs. Chalo, let's come to the previous question only. Does this patient have acidosis or alkalosis? This was his ABG, in which some of you wrote alkalosis, some of you wrote dono, or some of you wrote kuch nahi. Now let's calculate. I didn't say anything. Don't put laughter emojis. So let's calculate anion gap in this previous ABG, which you all wrote to be alkalotic or normal or whatever. Calculate anion gap. 42 nahi hai bhai. So in our new system of Ulta ABG, the first thing we check is not pH but anion gap, and the moment we see this pH, we know that this patient has high anion gap metabolic acidosis irrespective of what. Irrespective of his pH, he has a normal anion gap metabolic acidosis. Again, the ABGs I am putting up, they are not real ABGs. I have made them to look like normal ABGs. Just for the sake of your concept learning, this anion gap is 22. The moment you see an anion gap of 22, you know that this patient has HAGMA, high anion gap metabolic acidosis. Now, if pH is normal, then it is a mixed disorder. He could have had metabolic alkalosis also to compensate it, but he definitely has high anion gap metabolic acidosis. Right? So, irrespective of pH, we diagnosed a mixed disorder because pH is normal and still he has a high anion gap metabolic acidosis. Sorry. Again, let's try this one. Calculate anion gap. So in our ABG, we will have first thing as badhiya. I guess 15 minutes more, sir. Nipa should be coming to Indore for this to attend offline. Right. So this is high anion gap metabolic acidosis. So first step in our ABG analysis is, first thing we check is anion gap. If anion gap is high, then one thing we have diagnosed that this patient has high anion gap metabolic acidosis without even looking at the pH or PCO2 or bicarbonate or anything. And remember, this is the most difficult part of an ABG. So if we get rid of it in the first step, then we are good. In next step, if the anion gap is high, then it's fine. If the anion gap is normal, we will look at base excess. If the anion gap is normal, then we will go to next step, and that is base excess. I'm simplifying the steps. It can be complicated to bicarbonate gap and delta gap. Not right now. Just stick to the basics. If the anion gap is normal, then we'll check base excess. What is base excess? Base excess is metabolic component of acidosis or alkalosis. Got it? No? Simple. Base excess is metabolic component of acidosis or alkalosis. The normal value is -2 to +2. If it is way negative than -2, then there is metabolic acidosis for sure. If it is way positive from +2, then metabolic alkalosis is for sure. Again, we go to next step. If an anion gap is normal, we check base excess. Base excess is metabolic component of acidosis or alkalosis. If base excess is too negative, like -6 to -8, then we have metabolic acidosis, but non-anion gap type. Why? Because anion gap is normal, and if there is still base excess negative, then it is non-anion gap metabolic acidosis. फिर से समझाऊंगा. First step, you check the anion gap. If the anion gap was like 20, 22, you know that it is HAGMA. Leave it. Next step, check for base excess. If the anion gap is normal and base excess is still too negative, then it is acidosis. Why? Base excess is negative. But it is non-anion gap acidosis because the anion gap was normal. So easy. Look at this ABG. एक्चुअल बाइकार्ब, स्टैंडर्ड बाइकार्ब, ये सब छोड़ दो अभी. Calculate anion gap, na? The anion gap is 12, but the bicarbonate is 2 less, or maybe the base excess is -5. So this is metabolic acidosis, normal anion gap. There are only two reasons for non-anion gap acidosis. One is the body is losing bicarbonate through kidneys, and the other is the body is losing bicarbonate through gut. Again, let's summarize acidosis. Acidosis can be because of two reasons. A, some external acid came, H2SO4 in our example, but in real life lactic acid, or some diabetic keto acid, or maybe ethylene glycol and all those mud piles. In metabolic acidosis, if there is an external acid, some bicarbonates will go and fight that external acid and they will get shaheed. The loss of bicarbonate will be balanced by the unmeasured anions, which will contribute to the anion gap. So if an external acid is attacking, there will be high anion gap metabolic acidosis. If there is no external acid, and let's say the kidneys are leaking or the gut is leaking and the gut is shedding bicarbonate like anything, then the patient will have reduced bicarb but normal anion gap. He will still have acidosis because he has lost bicarbs. Like we started, the blue side is becoming weaker. And this reduced bicarb is not because of fighting with an external acid, but because of losing the internal bicarb. This happens in two diseases. One is renal tubular acidosis and the other one is diarrhea. Again, calculate anion gap. It is how much? It is, let's calculate quickly. And what is the anion gap? Not 12, 10. Okay. The anion gap is 10 and the base excess is still negative. Anion gap is normal and still the patient is acidotic. We haven't got to the pH yet. Still, there is non-anion gap metabolic acidosis. So we diagnose the most two difficult things to diagnose in an ABG by looking at two simple things: sodium sodium chloride bicarbonate, and then base excess. After that, if the anion gap is normal and if the base excess is also not very negative, then it could be only two things. So anion gap is normal. If it is raised, it is HAGMA. If it is not, then we check base excess. If it is low, then it is NAGMA. If both the things are normal, I am not going to the alkalotic side. That is also normal. We will check the pH and PCO2. So a patient doesn't have metabolic acidosis. We checked for HAGMA, we checked for NAGMA. He doesn't have HAGMA, he doesn't have NAGMA. So all we have to do is to check the pH, bicarb and Carbon dioxide. And we will know the same tug of war and we'll know what is going wrong with him like we did in the first 4 slides. So what we'll do is, if the pH is low and the PCO2 is high, it is respiratory acidosis, I told you earlier. If the pH is high and PCO2 is low, it is respiratory alkalosis. And there could be a possibility that the pH is high and bicarb is high. It could be metabolic. Then those will be more like simple disorders. So I think our time is almost getting over. So let's do it with like 2-3 questions. You answer in the chat box. You have everything at your hand. First step, I'll explain base excess again. Base excess is the metabolic component of acidosis or alkalosis. So if base excess is much lesser than -2, -6, -8, then it is metabolic component of acidosis. If base excess is +8, +10, it is metabolic component of alkalosis. So what is this? This is the base excess is, the anion gap is normal. The base excess is also normal, right? Anion gap is normal. It is not NAGMA. It is not HAGMA. It is not NAGMA. Now we check the two things. PCO2 looks higher side and the pH is less. That is, the red team has become stronger and the pH is towards the pink side. This is respiratory acidosis because bicarbonate is almost normal. This is primarily respiratory acidosis, which is partially compensated, very little compensation. This is most likely acute injury. So this is acute respiratory acidosis with minimal compensation. When will we say NAGMA? We'll say NAGMA when a patient is having normal anion gap and still low base excess. Normal anion gap and base excess -5, -7, something like that. ठीक है, अगला देखते हैं. Again, look at the anion gap. Normal. Look at the base excess. Again normal, -2 से +2 normal. Bicarbonate looks more towards normal. PCO2 looks lesser side. So bicarbonate means the blue side has the normal number of wrestlers. The red side has lost some wrestlers. The red side has lost some wrestlers, and there is alkalosis. So what kind of alkalosis this should be? तब तक तो लोगों ने लिख दिया already. This is acute respiratory alkalosis with minimal metabolic compensation. Third, try this. Anion gap calculate करेंगे, नहीं है. अगर होता तो HAGMA. Base excess देखने गए. Base excess is on the positive side. So there should be a component of metabolic alkalosis. There is no HAGMA, there is no NAGMA. It is metabolic alkalosis for sure. PCO2 is just trying to compensate. Primary metabolic alkalosis with partial respiratory compensation. Now, last 5 minutes of this webinar, if you attend it completely, then you will get a wonderful gift from my side also. I mean, Sukhvinder sir is also giving you a lot of gifts, but I will also give you something to take home with. How to treat metabolic acidosis? Tell me, बहुत आसान है. How to treat metabolic acidosis? थोड़ा सा पानी देते हैं.
Everyone, please type the answer in the chat box. How to treat the metabolic acidosis? Sir is asking.
लिखो. हाँ, सोडा बाइकार्ब नहीं लिखा किसी ने? हाँ, लिखा. 50-50 है, चलो कोई बात नहीं. So how to treat metabolic acidosis? Soda bicarb? No. Why? If somebody has got an infection and he's having fever, will paracetamol cure it? No, it will not. Soda bicarb is not the cure for metabolic acidosis, any kind of. So when to give soda bicarb? First and foremost, in hyperkalemia. Then there are only 3-4 indications to give soda bicarb. One is hyperkalemia. Other is treatment of sodium channel blocker overdose with ECG features, like tricyclic antidepressant ka overdose. This is for your theory exams or vivas. Then for urinary alkalinization. And in acidosis, there is only and only one indication for soda bicarb, and that is NAGMA. Because in NAGMA, body is losing bicarbonate. So you have to give bicarbonate. In HAGMA, there is no natural deficiency of bicarbonate. There is attack of an external acid. So if you keep giving bicarbonate, it is not going to help, right? You have to counter that external acid. That external acid is usually lactic acid because of the cause, the hypotension, the lack of perfusion, the sepsis, and you have to treat the cause. So the only indication in acidosis for bicarb is NAGMA. In NAGMA, you will give bicarb. I won't teach you the formula for calculating the bicarb deficit. That again is fact-based learning. You will get it everywhere. Standard versus actual bicarb, you will get it everywhere. Here we'll focus on concepts. So how will you treat metabolic acidosis? Again, I'll ask. You will treat by not soda bicarb, but by other things. We will treat the cause. We will treat the shock by fluid or inotropes. We'll treat diabetic ketoacidosis by fluid or insulin or whatever. We'll treat sepsis by antibiotics. How will we treat respiratory acidosis? Again, I'm not teaching alkalosis. How will we treat respiratory acidosis? I told you there are two buttons on your ventilator. One is respiratory rate and other is tidal volume. How much to increase? That is an interesting question. Okay, let's delve here. Hata the chat box. Let's say somebody has or should have a normal minute ventilation of 6 liters and his PCO2 should be 40. How do you calculate minute ventilation for a person? It's easy. We multiply the weight by 100. If somebody has a weight of 60 kgs, we multiply it by 100, we make it 6000 ml, yani 6 liter of minute volume. If we put somebody on ventilator, how do we calculate minute volume? We calculate it by multiplying his weight by 100. If somebody is 75 kg, we want to give him 7500 ml of minute volume. I am not going into bariki. Just increase the minute volume. The minute volume should be 100 times of his weight. Now, if somebody has a weight of 60 kg, his minute volume should be 6 liters. His PCO2 should be 40 on that minute volume. What if his PCO2 has become 60? His PCO2 has increased by 1.5 times. So we will increase the minute volume by 1.5 times. So how will we calculate treatment of respiratory acidosis? We will proportionately increase the minute volume, of course in normal human ranges, to the percentage increase in PCO2. So if somebody has a like 30% increase in PCO2, we will try to increase the minute volume by 30%, right? So if CO2 has gone from 40 to 60, 1.5 times, and the minute volume is 5 liters, we'll try to take it to 7.5 liters for a while, not for always. Okay? So what have we learned so far? I have given you PaO2, PCO2. I have given you basic acid base. How does the acidosis and alkalosis fight, and how do they eventually lead to acidemia and alkalemia? They can, a person can have a normal pH despite having both acidosis and alkalosis. And how does compensation work? Then I told you about anion gap. What if we want to go beyond that? I will not go into standard bicarb, actual bicarb, or कौन सा एक और होता ना stat pH and एक और तरह की pH होती है, मुझे तो याद भी नहीं रहता है सब. I have done a different thing. What I have done is, hello, just a minute, I'll be winding up in 2 minutes, sir. if we want to do more than that. So as it was read in my CV, I am an technology enthusiast, I am a AI enthusiast and all. So I have been working on an AI-based ABG interpreter. I have connected it to WhatsApp. And what you can try is, you can just send a WhatsApp message to this number, 782896585. Just say hi. It will say, hi, I am ABG interpreter so-and-so. And just give him real values. Don't try to complicate things by giving a bicarb of 0 and a PCO2 of 200. Just try to give him actual ABGs you get in your ICUs, the actual ABGs, and let it interpret them. I am changing the algorithm constantly from the backend, and you just test it. You tell me when it went wrong. It will go wrong in maybe these complex disorders, when there are triple disorders. I'm trying to work on the formulas for that, but try this. Eventually, the future is AI. There will come a time like ECG, the report is written. Similarly, there will come a time not very far from now when ABG reports will come with an interpretation and maybe even a suggestion. So what I would suggest all of you is just send a WhatsApp to this number. Just save this number as Subodh Chaturvedi or whatever. Just save this number. This number is for one thing only. I am monitoring it from the backend, but this number is attached to an API of artificial intelligence, and just feed him your ABGs and test it, and just do give me feedbacks with the screenshots. Ke, sir, this interpreted this ABG as wrong. It will be correct like 70-80% of times. You'll enjoy using it. Just don't give it absurd value. Just give him normal routine day-to-day ICU ABGs, whatever the acidosis and alkalosis be. So try this and do tell me, save this number.
Pictures or type messages.
So my part of this lecture is over. Now I'm open for questions. I don't think there should be any questions.
Now the topic is open for discussion.
So
Any
Dr.
questions can be asked?
has raised his hand.
थोड़ा सा पानी दे दो यार मुझे.
Dr. Pankaj Punch has
Dr.
raised his hand.
Pankaj. Hello.
Just let Dr. Subodh have some water.
Yeah.
So he will take some break.
Chat box दिखा दो. Sir, in the last questions, base excess was +9 and anion gap is normal. See, then it is NAGMA. No, for NAGMA, you have to have acidosis. Now, base excess is on the positive side. Base excess shows metabolic component of acidosis or alkalosis. If base excess is towards negative side, -2 ki jagah, if it is -9, then it is in the previous exam, in the same example, if the base excess was -9 and anion gap was normal, then it is NAGMA. But it is +9 and then anion gap doesn't matter, it is metabolic alkalosis. No, not, it will be this, क्या नाम है लड़के का? Devrat. Devrat, you just have to write the values. Right now it is not accepting pictures.
Hello.
हाँ जी मैम.
So one of them have asked if there's a specific pH as in 7 to 7.1 to start bicarb for
soda
correction.
bicarb for correction. Again, I had a few more slides on soda bicarb. I just didn't show them. But then soda bicarb, you should refrain from giving unless until a patient is dying of cardiac arrest or something. And even in cardiac arrest, it is not a good idea to give. There are not many things. I have a few slides. Maybe you can take a screenshot or something why soda bicarb is bad and why it is too osmotic and too too problematic for your veins. So you are increasing the osmolarity by too much and lot of things. And it is harmful for peripheral veins. Why shouldn't you be giving soda bicarb, peripheral vein thrombophlebitis and all those things that happen because of soda bicarb. So ultimately you should be trying to treat the cause instead of doing anything else. Right? It shouldn't be given in cardiac arrest with severe acidosis. or diabetic ketoacidosis, or if bicarbonate level is approaching 0, in these things it should not be given.
Sir, there was one query by Dr. Allen. If CO2 and bicarbs are grossly
Take
deranged,
the
but the
screenshot.
pH
Somebody is
is
saying
not.
it's difficult to take screenshots. Take a screenshot, yeah.
If CO2 and bicarb is grossly deranged and pH is normal, is there any need for intervention?
एक मिनट
Dr. Allen has raised.
कहाँ गया मुझे क्वेश्चन रीड करवा दो ना.
We'll get more thank you. You won't see the question here. Let Jitu please help Dr. Subodh with the question again.
Sir, it was a previous question, sir. I have just noted it down. Dr. Allen had asked, what if CO2 and bicarbs are deranged and pH is normal? And is there any need for intervention?
The pH is normal because it is a mixed disorder, but it doesn't mean that there is no disorder. So you have to find the primary disorder and treat it. Why? I mean, the pH is normal, that's fine. But a person can be having three disorders: one metabolic acidosis, one respiratory alkalosis, and one metabolic alkalosis. All of them are combining to generate a normal pH somehow. But you have still to find the causes, which one of the them is the bigger enemy. Usually it is the metabolic acidosis, and treat the cause. This again, you can take a screenshot.
Sir, I think Dr. Pankaj wants to ask one question.
Sure.
Dr. Pankaj, please unmute yourself and ask.
Yeah, good evening, sir.
Good evening, Pankaj.
But I have been following you for quite some time, and this ABG, Ulta ABG is excellent method. My question to you is, and thank you very much for this concept-based teaching. My question is, why don't we use only this method for solving all the ABGs? Why don't we need all those formulas at all in the books anywhere else?
Sir, that is a complicated question to answer. But the thing is कि I mean, this method also, I mean, एक दिन बैठे ऐसे करते सोचा कि why not we try to do it in a reverse way? But then again, ideally you should be analyzing an ABG right from pH to anion gap. But this makes it easier. We as Indians, we are always trying to find jugads. So this is more of a jugad. That is the classical method of learning. So if somebody is writing in an exam about how to analyze an ABG, he should still be sticking to the traditional method.
I think, sir, you should make it the traditional one. The traditional one needs to go. Thank you very much.
Thank you, sir. Thank you so much, sir. Recording will be on YouTube channel, ISA.
Yeah, I've already sent it after the class. After the class, it will be available. Anybody can take screenshots and listen to the recording.
Bhanu Gaur is asking, please plan for a ECG class. There are 2 ECG classes on ISA channel only.
Okay. So they have asked why soda bicarb is not given if bicarb is less than 5.
Why में क्यों पढ़ना? नहीं देना. ये ले लेना. This is very important.
Any other queries?
Can I wind up, sir?
As you wish. I think the questions are almost every question was answered on the screen only.
Sir.
And a few doubts were there. I think still in the small class, everything is almost answered in the best way. And even my 3-4 doubts are also been cleared.
Hurry, sir.
No, I was also following the class actually properly. So my 3-4 doubts were there. I think cleared only.
Thank you so much, sir.
Wonderful class. Dr. Madhuri has doubts still.
Sir, I don't have doubts, but I'm really inspired by your teaching. Your teaching is in tune with the modern times, and
Thank you so much.
I think as like I'm very interested in medical education, and the way you taught, the way you connected with your students, and the your communication, everything. Your teaching skill is excellent, sir, and you really taught in a very effective way. Very, very inspiring, sir.
Thank you, ma'am. Thank you so much, ma'am.
एक
Anybody wants?
कॉम्प्लीमेंट दे दूं सर? सर एक कॉम्प्लीमेंट और दे दूं मैं आपको, सॉरी सर।
जी सर, जी सर।
आपके ये उल्टा मेथड से ये जो मैं फॉलो कर रहा हूँ यूट्यूब से देख के आपको,
जी
वो
सर।
मैं दुबई बेस्ड हूँ, तो ये लोगों को यहाँ पे इतने शौक मिलते हैं, इतने शौक मिलते हैं, और मेरे को इतना मजा आता है। थैंक यू वेरी मच।
थैंक यू सर, थैंक यू सो मच सर।
Dr. Parna Thakur also has raised her hand. Ma'am, can you please unmute?
Superb class. Superb class. I don't know if my PGs have attended, but I enjoyed the class thoroughly. Too good, sir.
Thank you, ma'am. Thank you so much.
Cheers, 3 cheers. Very nice.
I was expecting a question from you, Dr. Parna, not the compliment.
Actually, I joined halfway, but superb. Too good. Thank you so much, sir.
Chaliye sir.
So, I will now, it's a time for us to do some felicitation also.
Yes, sir.
Just let
So I'll have to come there, ma'am.
you can remove the spotlight,
Yes, sir.
Subodh sir.
Yes, sir. Kar raha hoon.
Now it's visible.
Yes, sir. Yes, sir.
So, Subodh sir, this is a certificate of a small gesture from ISA National
Thank you,
Headquarters.
sir.
The wonderful class today, and it will be beneficial for the PG students who may not have attended today. They can go to the YouTube and view the ISA NHQ channel. So this class will be available for a lifetime for them. Anybody can, before the examination, this class will be good for them to clear their doubts, as it has cleared many doubts of many people here in the present class. So thank you, sir, for being a teacher in this class. We appreciate your time, dedication, and the new innovations in teaching also, for such a complicated and yet making it very simple for everyone. Thank you, sir, for that.
Thank you, sir. Thank you so much, sir.
And Jitu, thank you very much for being a screen coordinator for this class. You're very agile and vigil whenever the questions were there. So you have copied everything on your desktop or laptop, and it was good that you remembered every question. And similarly, Sarina also, she is equally vigil with you. So you both have done a wonderful job in conducting this class. Because this class, I think it's difficult for screen coordinators to stick to the questions, because when they are themselves listening to the class, so still you were on the both sides. So that's a good thing. We appreciate your involvement here.
Thank you,
And
sir.
then we have got this one, our Dr. Madhuri, Dr. Nishan, Dr. Ridhima. They are all our, the class coordinators. Thank you everyone for being here as what you called a wonderful class coordinators, the class teamwork, the technical parts. So everything goes in making such classes a very good class for every PG students. I hope we will have some more class from Dr. Subodh in the coming days, very soon. And for the time being, I think it was wonderful. Everybody will have some memory about the ABG. Still, if somebody has got, the doubts, Dr. Subodh will be answering those things. Dr. Subodh, you can give the contact number or the contact email. They can give you the, the question they can ask you
Sir,
directly.
yes, sir. Sir, you can Gulas chat पे type कर दें.
You have got a
help at
YouTube.
clinicalguruji.com. HELP help at clinicalguruji.com is the email address on which you can.
You can type in the chat box, sir, and
Yes, sir.
people
Yes, sir.
can follow
Yes,
it, so they can ask the question anytime, whenever required.
Yes, sir.
So this was a good class. Anybody wants to say something before we close up? Any more suggestions?
Kindly ask our teacher in ISA PG class to have one more class on ECG.
Sir, I have
Viresham
had
sir,
an
already
ECG class.
ECG classes was taken by Dr. Subodh long time back, and
It
we
is
will
there
soon
on the
have. I
platform,
think
sir.
good evening.
we will do
Yeah.
the class again. Already this there on the ISA NHQ at YouTube.
Okay. Okay, sir. Thank you.
So I think that's all from our side. So finally, we say thank you to Dr. Subodh and to all the audience and the seniors and the students. So time to end the class today. And we always end by saying, long live ISA.
Long live ISA.
Long live
Yes.
ISA.
Long live.